It is wild to think that a little over a century ago, the absolute cutting edge of imaging technology was essentially just blindly throwing sound waves into the pitch black ocean.
Yeah.
Like they were literally hoping they would bounce off an enemy submarine.
Yeah, it really is crazy to think about. I mean, Professor Langevin developed that during the First World War, and he was using sound frequencies way beyond human hearing just to detect U-boats. It was purely a matter of survival, right? Just a way to map out this completely murky, hidden environment.
Right. And the translation of that wartime technology into modern medicine is just staggering.
Oh, absolutely. We use those exact same fundamental acoustics today, but obviously not to hunt submarines. We use them to safely look inside the human pelvis or, to watch a fetal heart beating before a patient is even born.
Which is incredible. And that technological leap is exactly what we are unpacking today in this custom deep dive. This is specifically tailored for you out there, whether you are a dedicated medical learner or young professional.
Exactly. We are acting as your guides today through the second edition of the Manual of Ultrasound in Obstetrics and Gynaecology. That's by Dr. Kakoli Ghosh Dastidar.
And our mission here is to really trace this whole diagnostic journey. We're going from the raw physics of the sound wave all the way through advanced Doppler techniques and the detection of complex congenital anomalies.
Yeah, and we're aiming for a scientifically rigorous synthesis here. The goal is to give you a comprehensive understanding of not just what you are looking at on the ultrasound monitor, but why the tissue presents that way.
Right, so you can actually apply these insights directly to your clinical practice or, your board exams. But to get to that level of clinical application, I feel like we have to start with the origin of the echo itself.
We do, yeah. Because generating a sound wave that can actually map the human body relies entirely on something called the piezoelectric effect.
Which was first described by Madame Curie, right?
Yes, exactly. And that physical property is really the foundation of the entire field. In nature, certain crystals just possess this intrinsic capability where if you apply an electrical current to them, their molecular structure vibrates.
So they actually move.
Right, they physically vibrate, and that produces mechanical pressure waves. And the really cool part is that the reverse is also true. When a returning mechanical pressure wave like an echo hits the crystal, it deforms it slightly and generates an electrical signal.
Okay, so the transducer you hold against the patient's skin is effectively acting as both the speaker broadcasting the sound and the microphone listening for the return signal.
That dual function is totally key. Modern transducers rely on artificially manufactured crystals now, typically lead zirconium titanate, and they're arranged in very specific arrays.
So when you press that probe down, you are sending those mechanical pressure waves deep into the pelvic tissues.
You are. But the clarity of the picture you get back is governed by the rule of frequency. Frequency is simply the number of wave cycles passing a given point per second.
Right. And the fundamental clinical rule we operate under is that higher frequency waves yield vastly better image resolution. But they suffer from decreased tissue penetration.
Exactly. It is always a trade-off.
Which is tough because, it's tempting to want the absolute highest resolution every time. But clinically, we are always fighting the physics of attenuation, right? Like, why wouldn't we just crank the frequency up to maximum for every single patient?
Well, because the clinical trade-off is just unavoidable. If you use a very high frequency wave for, say, a standard transabdominal scan, the sound energy gets entirely absorbed by the subcutaneous fat and the anterior abdominal wall.
Oh, wow. So it just doesn't even make it to the target.
Right. You end up with a beautifully high-resolution image of the patient's fat cells and just a completely dark screen where the uterus and ovaries should be.
Which means for a transabdominal pelvic scan, we deliberately have to select a lower frequency, usually around, 3.5 or 5.0 megahertz?
Yeah, roughly in that range, just to ensure the beam actually penetrates deep enough. But even with the right frequency, the manual really stresses the art of patient preparation, specifically the absolute necessity of a full urinary bladder.
Right, because a transabdominal approach is essentially useless without that full bladder, and it serves two distinct mechanical purposes, doesn't it?
It does. First off, as the bladder fills with urine, it expands and physically pulls the uterus, the fallopian tubes, and the ovaries upward. It literally brings them out of the deep hidden pelvis.
Which is mechanically brilliant. And the second purpose?
Fluid transmits sound waves perfectly without absorbing them, so the full bladder acts as a pristine acoustic window. It allows the sound waves to travel completely unimpeded to those posteriorly placed organs.
There is a recognized clinical trap here, though, that we have to talk about. An overfull bladder can actually compromise the entire scan.
Oh, definitely. Too much fluid creates mechanical compression. If the bladder is overdistended, it physically crushes the pelvic organs.
Oh, wow. So it distorts everything.
Exactly. It distorts the cervical canal, it obscures the internal us, and it can easily lead a clinician to falsely diagnose a condition like placenta previa, or it just makes it impossible to accurately measure developing ovarian follicles.
Right. So to bypass the abdominal wall and all those bladder issues entirely, the field developed transvaginal sonography, or TVS.
And TVS completely changed the landscape of gynecological imaging. Because you are placing the transducer mere millimeters away from the pelvic organs, you eliminate the need for deep tissue penetration.
So you don't have to fight the attenuation as much.
Exactly. This allows you to safely utilize a much higher frequency transducer, and that gives you vastly superior, almost microscopic resolution.
Plus, it's the ideal approach for obese patients or for easily visualizing retroverted uteri that hide really deep in the pelvis. And thankfully, the patient doesn't have to endure holding a painfully full bladder.
Which is a huge relief for the patient, obviously. And with that high-resolution TVS image, characterizing specific pelvic pathologies becomes much more definitive. The manual outlines really clear sonographic signatures for conditions that often present with, identical clinical symptoms.
Like heavy bleeding and pelvic pain. Distinguishing a leiomyoma, which is commonly known as a fibroid, from adenomyosis is a perfect example of this.
Yeah, because on a clinical level, those two conditions require very different surgical or medical management. So the ultrasound diagnosis is absolutely critical.
So how does a leiomyoma present on the screen?
It presents as a discrete hypoechoic mass. Hypoechoic meaning it appears darker on the monitor because the dense fibroid tissue doesn't bounce as many sound waves back to the probe.
Ah, okay. And it usually has a heterogeneous texture and physically distorts the external contour of the uterus, right?
Exactly. And importantly, fibroids often cause acoustic shadowing. That looks like a dark streak behind the mass where the sound waves were entirely blocked. Plus, they frequently show areas of bright white calcification.
Adenomyosis, however, is a diffuse condition, right? Where the endometrial tissue improperly invades the muscular wall of the myometrium, so it doesn't look like a singular lump.
Right, the presentation is entirely different. You will not see a discrete mass at all. Instead, the entire uterus just appears diffusely enlarged. The myometrium looks heterogeneous with these small myometrial cystic areas scattered throughout.
And what's the biggest giveaway on the scan for that?
The most telling sonographic sign is a remarkably poor definition of the endometrial-myometrial interface. That boundary, which should be a crisp, clear line, just becomes thoroughly blurred.
Being able to see that level of cellular invasion completely revolutionizes reproductive medicine. I mean, the text highlights how diagnostic ultrasound became the indispensable tool for post-IVF breakthroughs.
Oh, absolutely. It directly contributed to the historic births of Louise Brown in the UK and Durga and Imran in India. Treating infertility requires tracking the endocrine system as it physically remodels the pelvic organs in real time.
It's basically like setting up a time-lapse camera inside the body. We do this through a serial ultrasound study called folliculometry, right? Which typically begins on day 3 of the patient's menstrual cycle.
Exactly. We are monitoring the progressive growth of the ovarian follicles to pinpoint exact ovulatory status. But we aren't just looking for the follicle to reach maturity.
We have to actually witness the physical rupture of that follicle and the subsequent formation of the corpus luteum.
Yes, confirming that rupture is vital. Because if the follicle matures but fails to release the egg, the patient has luteinized unruptured follicle, or LUF syndrome.
Oh, so without ultrasound, you might look at hormone levels and just assume normal ovulation occurred.
Right, while the egg actually just remains trapped inside. Simultaneously, we use the scan to monitor the endometrium. The uterine lining has to develop a very specific layering pattern and reach a precise thickness to successfully receive an implanting embryo.
Ultrasound is also the primary diagnostic tool for polycystic ovarian disease, which the manual notes was first described anatomically way back in 1721, centuries before we could actually image it non-invasively.
Which is wild. And it also spots endometriosis, specifically the characteristic chocolate cysts in the ovaries. Those appear as complex cystic structures filled with old, thickened blood.
Those structural details are definitely essential, but grayscale imaging has its limits, doesn't it? Like if you are looking at a cystic structure in the adnexa next to the uterus, it can be incredibly difficult to differentiate a normal benign luteal cyst from a highly dangerous ectopic pregnancy just by looking at the shades of gray.
It is extremely difficult, which is why we overcome that limit by moving from structural imaging to functional imaging. We actually add color to the screen by utilizing the Doppler shift
It is so fascinating to me how an astronomical principle translates directly into clinical practice here.
Sure.
I mean, Christian Doppler presented his paper in Prague in 1852 about the red shift of double stars, tracking the movement of celestial bodies. And now we use that exact same physics to track microscopic red blood cells.
Yeah, because the physics holds true whether you were looking at a galaxy or a capillary. In medical ultrasound, the Doppler shift measures the change in frequency of the sound waves as they bounce off red blood cells, moving either toward or away from the transducer.
And this functional vascular data is how we solve that ectopic pregnancy dilemma, right?
Right.
Because ectopic pregnancies increase maternal mortality tenfold compared to a normal delivery if they go undetected and rupture.
The stakes are just immense, particularly because the incidence of heterotopic pregnancies, where a patient has one viable embryo in the uterus and a simultaneous ectopic embryo in the fallopian tube, has skyrocketed. It went from 1 in 30,000 to nearly 1 in 7,000, largely due to the rise in infertility treatments.
So because the risk is so high, we are looking for a very specific vascular footprint on the scan.
We are. Developing trophoblastic tissue, which forms the early placenta, requires a massive, really aggressive blood supply. So when you apply color Doppler to the adnexa around a suspected ectopic sac, you will see a classic ring of fire flow pattern.
A ring of fire. And the machine registers that as high velocity and low impedance, meaning there is very little resistance to the blood flow, plus high diastolic flow.
Exactly. And you pair that functional vascular data with the structural data. So you look for an empty uterus or a uterus showing a pseudodecidual reaction.
Which is basically a thickening of the uterine lining that mimics a true pregnancy sac, but is actually completely empty.
Right. That combination of a highly vascular adnexal mass and an empty uterine cavity gives you a definitive, life-saving diagnosis. And this same functional application of Doppler is equally critical in oncology.
Specifically regarding neoangiogenesis in ovarian malignancies, because when malignant tumors grow rapidly, they are forced to build their own blood supply. But the manual emphasizes that these newly formed tumor vessels are structurally defective compared to healthy blood vessels.
Yeah, and that structural defect is exactly what allows us to detect them on ultrasound. A normal, mature blood vessel contains a muscular media coat within its walls. That muscle layer allows the vessel to constrict, providing natural impedance or resistance to the blood flow.
And because of that resistance, blood pulses through normal vessels. You see a high flow rate during the heart's contraction, which is systole, and a low flow rate during the resting phase, diastole. This creates a high pulsatility index.
But the hastily built vessels in a tumor, they lack that muscular media coat entirely. Because they have no muscle layer, tumor vessels are essentially just rigid, open pipes.
Wow, okay, so they offer zero muscular resistance.
Zero. Consequently, the blood simply rushes through them continuously, maintaining a high flow rate even during diastole. This continuous low-resistance flow causes the pulsatility index, or PI, to drop significantly.
And the manual notes that a PI of less than 1 is a highly accurate marker for differentiating a malignant ovarian lesion from a benign one. So a PI of less than 1 physically translates to there are no muscles in these blood vessel walls.
Precisely. We've seen how Doppler tracks blood flow to find dangerous tumors or ectopic pregnancies. But that same functional imaging is exactly what allows us to look at the other end of the spectrum to obstetric ultrasound and fetal development.
Yeah, let's get into the obstetric timeline. The manual lays out a really strict developmental timeline. Fertilization occurs roughly 24 hours post-ovulation. The zygote implants by day 23. And from that point until the 10th week of gestation, the developing life is strictly classified as an embryo.
And the clinical objectives for ultrasound shift drastically as that development progresses through the trimesters. In the first trimester, up to 12 weeks, our primary goals are structural confirmation and precise dating.
So we look for the gestational sac, the yolk sac, and embryonic cardiac activity. And most importantly, we measure the crown rump link, or CRL.
Right. Because early embryonic growth is remarkably uniform across all pregnancies, the CRL in the first trimester remains the absolute gold standard for establishing an accurate due date.
The manual also includes a fascinating proportional milestone during this first trimester. At exactly 8 weeks gestation, the diameter of the yolk sac is actually equal to the diameter of the fetal head.
Yeah, it's pretty amazing.
It really is. It highlights the unique transient biology of early embryology. It's like an astronaut having a life support backpack that is the exact same size as they are. The nutritional support structure is just as massive as the developing neural center.
That's a great way to picture it. And the anatomy changes so rapidly. By the second trimester, the clinical goals expand. We confirm ongoing fetal viability, we quantify the amniotic fluid volume, and we localize the position of the placenta to ensure it isn't covering the cervix.
And crucially, the window between 14 to 16 weeks is the optimal time to perform a comprehensive anatomical screening for congenital anomalies. Then, by the third trimester, the focus shifts yet again, right?
It does. We assess fetal growth trajectories, evaluate the liquor volume, and conduct a biophysical profile.
And the biophysical profile is really where we transition from purely anatomical checks to functional neurological checks. We are watching the fetus breathe, observing its muscle tone, and looking at gross body movements to ensure the central nervous system is functioning properly before birth.
And the ability to assess that fetal well-being non-invasively, it represents a massive shift in obstetric care. Historically, detecting congenital anomalies relied heavily on invasive biochemical tests like amniocentesis.
Which carries a 0.2 to 0.5% risk of inducing an abortion. Plus, the clinical team has to wait weeks for the extracted cell cultures to actually grow in a lab.
Exactly. And the alternative was maternal serum alpha-fetoprotein, or MSAFP, which has its own severe limitations. It frequently returns false positives if the patient is carrying twins, or if the gestational dating is even just slightly off.
So ultrasound bypassing those risks is just vital, because the psychosocial weight of an anomalous birth is immense for the patient.
The emotional and financial impact completely alters the trajectory of a family's life. The manual actually quotes Professor Stuart Campbell, noting that the early neonatal care for these severe conditions far exceeds a man's lifetime earning.
And developmentally, the text specifies that days 15 to 65 post-conception represent the most vulnerable window for these structural anomalies to develop. So if days 15 to 65 are the critical window, what are the earliest visual red flags you can spot on the screen? I know abnormal fluid buildup is a primary marker.
Fluid buildup is a major indicator, yes, specifically neutral translucency. This is a collection of fluid at the back of the fetal neck, and an increased measurement there is a really strong sonographic marker for trisomy 21 or Down syndrome.
Okay, what else are we looking at?
We also heavily scrutinize the umbilical cord. A normal cord contains 2 arteries and 1 vein. Identifying a single umbilical artery, or SUA, is a significant red flag. Type 1 is the most common presentation of an SUA, and it carries a high association with severe central nervous system and genitourinary anomalies.
Identifying gastrointestinal anomalies is another major focus, and it is a classic point of clinical confusion for medical learners, specifically differentiating between an omphalocele and gastroschisis.
Oh, definitely. Even though they're both abdominal wall defects, their sonographic presentations and their genetic implications are totally different.
So for the learner out there trying to prep for boards, how do we break down the exact sonographic differences between the two?
Okay, differentiating the two is a high-yield concept. Think of an omphalocele as a central midline defect. The fetal bowel, and sometimes the liver, herniates directly into the base of the umbilical cord.
Okay, so on the monitor, you will clearly see the herniated organs contained within a membranous sac, right? And the umbilical cord will be seen inserting directly into the center of that sac.
Exactly. And clinically, omphalocele carry a very high association with chromosomal abnormalities, predominantly trisomy 13 and trisomy 18.
Gastroschisis, by contrast, is usually an isolated, sporadic event, right? It doesn't have those heavy genetic associations.
Right, and its visual presentation is distinct. Gastroschisis is typically a right-sided perumbilical defect. There is no membranous sac covering the organs at all.
So on the scan, you'll just observe free-floating loops of bowel suspended in the amniotic fluid?
Exactly. And because the defect is located beside the umbilicus, the insertion point of the umbilical cord into the fetal abdomen will actually appear completely normal.
Okay, that makes it very clear. So a membranous sac with central cord insertion points to omphalocele, while free-floating bowel with a normal cord insertion points to gastroschisis.
That is the perfect summary. And the ultrasound can also detect profound musculoskeletal and neural issues. Neural tube defects, for example, are seen in roughly 1 in 500 births.
The technology is sensitive enough to even detect bone demineralization, which is indicative of osteogenesis imperfecta, or, the specific cloverleaf skull shape that is a hallmark of thanaphoric dysplasia.
The sheer diagnostic power really is staggering. But that naturally leads to the final looming question that is addressed in the manual. Is it completely safe?
Which is the most responsible question a clinician can ask, really.
It is. The broad consensus from organizations like the AIUM and NCRP is that diagnostic ultrasound is safe, provided it is used prudently.
The text does note there have been laboratory reports of sister chromatid exchanges, or SCE, occurring in human lymphocytes exposed to pulsed ultrasound in vitro.
Yes, but the critical context there is that absolutely no genetic effects have ever been proven in humans, nor in animal experiments followed out through 20 consecutive generations.
Still, playing devil's advocate here, if there's absolutely no proven genetic effect in humans, there are still theoretical mechanisms of harm to consider, right? Like, the tissue absorbs acoustic energy, which creates a heating effect, and the pressure waves cause mechanical effects like cavitation.
Which is precisely why prudent use guidelines exist. Pulse Doppler utilizes much higher energy levels than standard grayscale imaging, so clinical guidelines generally recommend avoiding its use during the very first few weeks of gestation when the embryo is in its absolute most vulnerable developmental state.
The manual also highlights a mechanical limitation later in pregnancy. It notes that continuous Doppler monitoring for prolonged periods during labor is linked to erythrocyte fragility. What does erythrocyte fragility actually mean for the patient? What does that wear and tear look like at a cellular level?
Erythrocyte fragility means the red blood cells become structurally compromised. If you continuously focus a beam of high-frequency sound energy onto a localized area of flowing blood for hours during a prolonged labor, the constant mechanical vibration physically stresses the delicate cell membranes of the red blood cells.
Oh, I see. So it's basically vibrating them until they break.
Right. Over time, that stress makes them fragile and prone to rupturing, a process called hemolysis. It is not genetic damage, but it is a clear example of mechanical wear and tear, which dictates exactly why we limit continuous exposure.
Which brings us perfectly back to the core lesson of the text. Respect the physics. From Madame Curie's discovery of vibrating crystals, to understanding why tumor vessels lack a muscular media code, to safely, non-invasively assessing a fetal biophysical profile, ultrasound is just an unparalleled diagnostic tool.
But its power relies entirely on an operator who actually understands the why behind the image on the screen. Knowledge only improves patient outcomes when it is deeply understood and correctly applied. Knowing the physical mechanisms behind the echoes makes you a true diagnostician rather than someone just taking a photograph of the pelvis.
Absolutely. And to ensure that knowledge sticks, we want to leave you, the listener, with a practical clinical exercise to mull over.
So, based on what we covered today, imagine you are performing a transvaginal ultrasound on a patient with a suspicious adnexal mass. You switch on the color Doppler and note a high-velocity, low-impedance blood flow with a pulsatility index of 1.7.
Based on that functional vascular data, what specific cellular feature is missing in those blood vessels, and what is your primary clinical diagnosis? Take a moment to really think through the physics, and just for your self-study. The vessels lack a muscular media coat, which indicates the rigid pipes of neoangiogenesis, making your primary diagnosis a highly suspected ovarian malignancy.
That's spot on.
Thank you for taking this custom deep dive with us today.
Yeah.
Next time you pick up that transducer, remember, you are doing far more than taking a picture. You are sending a sonar ping into the dark and translating the echoes of life.